And in undergrad, I loved microbiology. And when I found out about Touro and pharmacy school, and all of those things just kind of clicked together. And I thought, this profession embodies helping patients, and communication's very important. And I get to also incorporate my love of micro all together. So it was a good fit.
Wonderful. Thank you. Thank you. What is one thing that you do as a pharmacist that you did not anticipate that you would be doing? There's probably not just one thing.
Yeah.
You can expand.
All of it. I think that a lot of people that aren't, I think the general population knows the pharmacist in the community that does dispensing. And then, beyond that, some people kind of understand their pharmacists that work in hospitals. But besides beyond the dispensing role, the role of using our knowledge base, something that can't be replaced by a machine or a technician. I had no idea that I would never really touch medication in my career. Like, I don't physically count pills or do any of that. I basically I'm an advisor to students, to physicians in conferences, and I just had no idea that we could do so much with a degree.
Thank you. Thank you. As a pharmacist, you've chosen to specialize in infectious disease. Why was this your choice? And what are some of the responsibilities of an infectious disease pharmacist?
Yeah, so great question. In undergrad, I was a bio major. I really liked pathophys and biology. And it was definitely my infectious disease professor in pharmacy school. I was really drawn to the topics. And when I started going on rotations, I saw how much value I could add to patient care. And there's a lot of people that really struggle with infectious diseases. It's not an easy topic because there's so many components that you have to consider when you're treating a patient. And I think that the complexity is what draws people into infectious diseases. Yeah.
Great, thank you. So COVID is front and center and has been a part of our life for going on a year now. What is your involvement with the efforts related to the COVID pandemic?
So in a medical center, academic medical center, we value education and knowledge and sharing. It's a very open environment, very collaborative environment. And thinking back to November, December of 2019, we're hearing about this novel virus in China. And we were talking about how it behaved, and it was, similar to SARS, and we're talking about Ebola. And so even before it reached the US, we were already thinking of what could we do? How would we treat this? What drugs would work and wouldn't work? And you've heard lots of things in the media about hydroxychloroquine and dexamethasone and all of these things. And so we were already looking at the literature and planning, not knowing the extent of what this would be. We were the first hospital in the US to diagnose a community transmission case. So I think that the fact that we talk constantly and we have formal meetings, we do journal clubs on Tuesdays and case conference on Friday, we were prepared. We had to tell the CDC, we have a patient, she's young, she's healthy, she hasn't traveled, and everything points to COVID. And they said, no, doesn't meet the criteria. And so we had to keep asking until they agreed to test the patient. And then she tested positive. And at that point we knew, okay, this is in the community now. So we've been very involved in the clinical studies. So research, because we want high quality data, not just, we heard that this works for patients, randomize controlled trials. And so we're definitely part of that, making sure that everything is treated appropriately. We've also been enrolling patients in vaccine trials as well. And then sharing information and disseminating information. We very quickly knew that it wasn't just an infectious disease issue. We needed to have our ICU colleagues involved, our cardiology pharmacists involved, inventory management. And so I had the opportunity to lead the UC-wide collaborative. And so we went from talking monthly to talking weekly among all of the UCs about patient care and drug supply.
Such a big
There's a
effort.
lot going on in COVID.
There is a lot
Yeah.
going on with COVID, and more to come. There's so much still to learn and to know. Thank you. Thank you so much for everything that you and your colleagues do. Um, so, in terms of career options for prospective pharmacists who want to focus on infectious disease, what would those career opportunities potentially be?
Yeah. You know, a lot of people sometimes say, I don't want to specialize because I don't want to narrow my options so much. And I just kind of smile and say, okay, even within a specialty, there are still so many more specialties. So I'm fortunate to be the residency program director for our infectious diseases program. And our graduates historically that train with us will either want go into academia full time. So we have people that are full time professors of pharmacy, infectious diseases focused. We have people that want to go into antimicrobial stewardship, which could be done in the hospital. There's now efforts to do more of that in the community, long-term care facilities. You can go into HIV care, hepatitis care. I have the dream job. I get to teach at the school at Touro University and practice at the hospital. So I get to share, you know, what we're doing in the real world in real time with the students, and then, you know, keep my connection with the school as an alum. And I also feel like it's good training for me to be a better communicator, because when I'm communicating with the students, am I doing a good job of explaining what we're doing in infectious diseases, or do I need to make what I'm presenting clearer, give more examples, more cases? And so you definitely, I see people track either into academia full-time, clinical care full-time, a mixed picture where they're doing both, or a very specialized, you know, HIV only, hepatitis only, or mixed.
Mm-hmm.
Yeah, lots of areas.
Mm-hmm. Talk a little bit more about, is it antimicrobial stewardship, and how pharmacists are helping with that effort? Did I pronounce that correctly? I feel like I may not have.
Yeah.
Yeah. Okay.
No, you got it. Antimicrobial stewardship. We abbreviate that ASP programs. When I was actually sitting in school at Touro, I remember my ID professor at the time, Dr. Brett Heinz, saying, ID is going to be a great field to go into because very soon Joint Commission is going to require stewardship in hospitals. And now it is a requirement. Joint Commission is an accrediting body. So if hospitals want to receive payment from Medicare, Medicaid, and kind of meet the gold standard of patient care, they have to have a stewardship program. And in the language of that document, it actually states you have to have a pharmacist leader of your stewardship program. And it has to be somebody that's received training in infectious diseases, not necessarily has to graduate from a postgraduate year two, a PGY2 residency, but some sort of certificate or some sort of specialized training. So that's now required for every hospital that has Joint Commission accreditation, and which is wonderful. The White House executive order was issued by President Barack Obama, also saying that stewardship is very important. We really need to protect and preserve the antimicrobials that we have and share resistance data among institutions. And so it's been wonderful to have what we do formalized and recognized, up to the highest level. So that definitely provides not only job security and job satisfaction, but gives us an opportunity to really showcase the kind of work that we can do for patients.
Great, great. Is there anything else that you would like to share with the audience about your particular career, your choices leading to that career, or just careers in pharmacy in general?
Yeah. I would think I was kind of, jotting down some notes before we started about really my role and what it is that I do, and the kind of hats that we wear. And it's definitely it's an educator advisor role, not only for learners. We have students that train with us and do rotations with us. So you have pharmacists that are learning how to work with patients. We have pharmacy residents in their first year and second year of rotation. And beyond that, we also have the medical staff. So you have medical students, medical residents, and physicians. In addition to that, I think a lot of us, as we're going through our career, we kind of set certain goals that we want to achieve. And publication is usually on people's lists. They want to publish in a journal. And then patient presentation or a presentation at a conference. And so there are a lot of conferences available, and being able to present at a pharmacy conference or a similar style conference. So for infectious diseases, we have ID Week, which is kind of our national conference. And then actually going on now, we have Society of Critical Care Medicine. And those are, national or international organizations. And we have the opportunity to attend and be part of those conferences. They're great for learning, for networking and staying up to date. And it's also kind of rejuvenating, and it gets you excited again. I remember one of the first times I attended a national infectious disease meeting, just the quality of the speakers, and thinking, wow, so impressive. I definitely want to do that someday and, get to that level.
Have you?
I have, yes.
Yeah.
I got my first national talk. It was Society of Critical Care Medicine. And that was on the wish list, one national talk. And for that conference, I got to do two. And I was invited back this year. So it's a great organization. And it's definitely an honor to speak for them. Yeah.
Congratulations. It's so nice to check those things off your bucket list.
Yes. Yeah. And now I have the opportunity to mentor and encourage other people to do that.
That is so awesome. So awesome. So what is your absolute favorite part of what you do? And there's probably so many. Yeah.
I think my favorite thing that I do is our Transitions of Care program. Transitions of Care is helping a patient move from the hospital to either they're going home or they're going to a facility. And in that transition, they may still require therapy. And my specific role or favorite part of that is kind of being a safety net for the patient. And so with our program that a lot of places don't have, this program of OPAT, we ensure that the patient is receiving the appropriate therapy. And so we kind of have like a check system. We've copied it from the airline industry. We ensure that they need antibiotics, and if they need them, does it have to be IV or can they be oral? Because if they can be oral, let's just avoid dealing with an IV line at all that could get infected or have complications. We ensure that the dose is appropriate for the patient, because patients come in all shapes and sizes and all types of organ function. So we want that customized dose. Then we also make sure that they have the appropriate labs that are being followed, because historically there can be patient harm if a patient is on a therapy and has electrolyte dysfunction or some sort of adverse effect. And we definitely don't want that to happen. And with that said, with that program, I'm able to not only optimize the patient's therapy and provide safe care with appropriate follow-up, but I can justify my existence to administration by saving central lines, the cost of putting those in, and by expediting discharge and getting patients out of the hospital. Most of the patients in our area are capitated. So the hospital is receiving a set amount of money regardless of the care they provide. And if we can get them home or get them to the next place, then we can free up that bed for somebody who needs it.
Yes.
And patients love getting out of the hospital. They don't want to be there. They want to go home if they can. And I love being able to recommend, oh, well, did you think of this drug? Or what if we try this? Or they'll call me and they'll say it's too expensive, and then trying to find an alternative. So I like those puzzles, and I like helping the patients that way.
Yeah, that direct patient care. That's amazing. That's amazing. And I think that's why most folks coming into the field of pharmacy, they're drawn to that patient care. But there's so much beyond that. And you are such a shining example of that. So as a TUC alum, what do you consider the most important features of the PharmD program at TUC?
I remember when I was looking at pharmacy schools when I was still an undergrad, and I was drawn to the TU program actually because of the dean. I knew historically that Dean Knapp had started pharmacy schools and worked at pharmacy schools before very successfully. And I knew because it was a new program, they were going to be on the cutting edge of their material, their curriculum, and their technology. And we see this reflected in UC San Francisco having to completely revamp their education over the course of the last few years because of the long-standing history. And so I knew I was like, I'm going to be getting, this is a great dean. I'm going to be getting great education. But it really actually came down to the instructors and the professors and the faculty. Just they're there because they want to teach and they have a heart for the students. They're not there because of the compensation. I mean, that's definitely a part of it, but you can tell that they're there because they want to be with they want to work with the students, they want to advance the profession, and they really care about the students.
Do you have any advice that you would give to someone considering the field of pharmacy, or people that are just certain that they want to be future pharmacists?
Yes, it's always great to try to reach out and get some more experience if you can. And whether or not that's just, a quick chat over the phone, or maybe a Zoom situation. Maybe after the COVID restrictions are lifted, it could even be a visit. In the past, I loved having students come over Friday mornings to join us for a conference and coffee. But if there's an area that you feel drawn to, go ahead and talk to somebody in that field. Most people do love talking about what they do. And so, a lot of people are shy, or they don't want to bother the person, or they think they're too busy, or you'll be surprised. You'll make connections that way. And you'll learn a lot more.
That is absolutely true. I know so many future pharmacists and folks that are considering entering the field of pharmacy, seeking opportunities to shadow their community pharmacists. And I know that it's just an amazing learning opportunity for them. Yeah. Before I open up questions from our audience, and I'm so glad that we have so many folks that have joined us this evening, I did want to make sure that I introduced Mr. Tony Williams, our recruiter here at Touro University, California. Tony is a wealth of information. I'm always happy to talk about the PharmD program here at TUC. Tony, if you wouldn't mind sharing your contact information in the chat for everyone to copy down in case they wanted to reach out to you, that would be fantastic. But I did want to ask Tony if you had any questions for Dr. Donnelley before I opened it up to the audience.
Absolutely. Dr. Donnellly, you obviously have a very rewarding career, one that you're passionate about. When in the program did you know ID was the path for you and not psych or any other specialty area? If you can kind of open that up a little bit and expound on that.
Yeah, it's I loved track 4 in pharmacy school. Track 4 is our therapeutics track where we really talk about how you treat the patient, right? We have the pathophys and the biology in track 1, and you've got the biochem in track 2, and track 3 we're talking about law and administration, everything. I really like the patient care, and I honestly didn't 100% settle on ID until I was in my first year residency. I think I always loved it, and I always kind of knew it was going to be infectious diseases. But it really took being in patient care and patient practice, because I also liked critical care. And I liked critical care because there was a lot the pharmacist could offer and do. And I was in the ICU. I remember this very specifically. I was in the ICU looking around at everybody on ventilators. And I thought, I really like these patients because I can help them and they're on a lot of antibiotics, but I want to see a mix of patients. I don't want to see ICU patients every day for the rest of my life. I like seeing them, and they're complicated and I want to help them, but I still want to see the pediatric patients because they're really cute. And I still want to see the 20-something-year-old who broke his leg skiing and can talk to you and is not on a ventilator. But I think that was the moment it was really solidified. And then we have a lot of elective rotations. And so I was fortunate to get to do electives in lots of areas. You don't always get all the electives you wish. I really liked pediatrics and oncology, and I didn't get to do those as a student, but I did get the experience during my first year residency. So, I mean, what you're kind of drawn through in the classroom is one thing, but once you're out in practice, I think that helps a lot more.
That's all my questions. Back to you, Jody.
Thank you. Thank you, Tony. I am going to open up the questions from the audience now. If you have a question, feel free to put your camera on and raise your hand, or you can raise your little virtual hand by clicking I think there is an option right under your name, or you can chat questions into the chat feature, and Tony and I will keep an eye on that as well. Does anyone have any questions for Dr. Donnelley? Don't be shy. Don't be shy. You're all here because you're either actively engaged in becoming a future pharmacist, moving towards that goal, or you're thinking about it. And so really, there is no better person to ask than someone that has walked this path that you are considering walking or currently walking as well. So don't be shy. Feel free to chat in those questions, or put your camera on and give us a shout out. Either way is fine.
Indeed. I echo that. I do see, while you're contemplating those difficult questions, and this is your moment, I did see Dr. Richie Duenas. He's hiding in the shadows. He's from if it is the Dr. Richie Duenas that's there, he is from the inaugural class, the very first class. And he's also a classmate of Dr. Monica Donnelley. Dr. Richie Duenas is not shy to speak. He's muted. And so I'm not going to put him on the spot, but I want to give him an opportunity to give a shout. And then please, we want to encourage you to post your questions in the chat. Dr. Duenas, you're on mute, sir. So if you want to share a thought or two. And this is Dr. Monica Donnelley's moment, but I want to acknowledge you, sir.
Yes, you certainly called me out. Can you hear me?
Yes, we can. Go for it.
Okay, I joined it because this is something new that Touro's doing, and have a feeling that y'all are going to ask me one day to be on it. So I took notes from Dr. Donnelley because she's such an influential person in our space. And I'm very proud to be associated with a university that, you know, can turn out good quality pharmacists that are passionate about their careers. So, you know, really, I think I'm also a very passionate person about my career. I mean, I'm on this right here because I want to learn about what it is we can do to inspire more people to get into this profession, because I think there is a lot of kind of fear before this last year about becoming a pharmacist, job prospects. And I think this type of webinar or town hall is important to share that, hey, this is an industry, a profession that is, you know, alive, about opportunity. And what more than this pandemic news about pharmacists' place in the role of care in the pandemic. So anything I can do to inspire more students, and yeah, I'm not too shy to talk, but then again, I'm actually here to support Dr. Donnelley, and, you know, just kind of learn from, you know, her talk here, because she's a great speaker. She's an expert in her space, and I just, you know, always want to help Touro where I can.
Thank you, Dr. Duenas. Much appreciated. I did not mean to put you on the spot, but I recognize your name. Please, we want to encourage you to ask your questions, as was mentioned. I'm going to turn it back to Jody to moderate here. If the questions and raising your hands, emotions, or what have you, or otherwise. Back to you, Jody.
Just real quick, I want to cut in and say that I'm very proud to have followed Richie Duenas from Touro. He was in the inaugural class, and today I saw him post a picture of a very nice trailer that looks like it's getting ready to do a lot of COVID immunizations. So I just definitely wanted to applaud you and thank you for that.
Thanks, Monica.
Awesome. Well, I am going to tap on the shoulders of names that I recognize that are actually going to be joining the incoming class. Oh, we have a question. Avneet.
Yes, I have a question for Doctor. So my question was, how was your residency experience? And what would you recommend students that are heading into their first year of pharmacy school starting this August? What should we do to prepare ourselves to apply for residencies if we're heading into that field?
That is a fantastic question. And I mean, very impressive that you're thinking about it already. I remember sitting in class my first year and somebody asking how many of you are going to do a residency, and maybe a few, you know, very few hands going up. And then the next question was, how many of you know what a residency is? So, you know, maybe a lot of your classmates aren't even aware of what happens during a residency. I remember when I heard about residencies, I thought my first thought was, I thought I was finishing with school. I didn't realize I was going to be more training, but we're going to be lifelong learners. We're going to constantly be staying up to date with the information. I think just the fact that you already know about it and you're already thinking about it is fantastic. You know, don't feel like you have to be involved in every single club and do every single thing. Try to just kind of listen and see what you're interested in, make connections with your faculty and the staff, and then just kind of sample areas that you want to learn more about. There's so many areas. I mean, I'm just here talking about infectious diseases, but there's, you know, work you can do in the community. There's AM care, intensive care, cardiology, nutrition, pain, so many things that I never even knew existed. Residency programs look for, you know, students who have put effort into that kind of area. If you are headed towards like the intensive care area, but you do a lot of electives in the community, you know, it doesn't kind of track with where you want to head. If you can get any kind of research experience, that's always a bonus. And there's a lot of clubs and opportunities during the school to do that. And then if, you know, if there's a topic you're interested, reach out to whoever teaches that topic to find out more about, you know, shadowing or working with them.
Thank you.
You're welcome.
I have a similar question, I think, in the chat from Navjot. And she asks, she states that she is currently in the process of picking rotations for next year. And wanted to know if you had any recommendations on some electives to diversify.
Yes, great.
Yeah, her experience.
Yeah, so I kind of think of it as a tool belt, and you're a pharmacist, and so you're going to be the drug expert in multiple areas, right? Not just in one area. I tried to maximize my experiences by picking very unique required rotations and then using my electives for the ones that I really wanted to do. So if I have to do a community rotation, I really want to do compounding. So how about I find a compounding community rotation? And I really want to spend some time in an ICU. So why don't I find an acute care that has an ICU so that I can save my elective to do something else? And so I think kind of think in terms of where you see your career headed. Do you see yourself doing community work? So you definitely want to get more experience in that area, but you know, you'll still have to do some hospital work, inpatient rotation. If you see yourself doing AmCare, get some strong rotations in that area, but but also give yourself some experience in some of the other areas. I got to speak with a 4th year student who's applying for residency, and they did rotation with the FDA. And what a fantastic experience to see how, especially right now, how drugs are presented and what they're asking for in terms of research. That's, you know, really valuable experience and very unique, and something you can talk about in your interview process. We've had P4s and P3s do rotations with the California Society of Health System Pharmacists, CSHP, and how a pharmacy organization advances the profession. You know, how do they deal with legislation? So there are definitely lots of opportunities out there. But I definitely wanted to focus on kind of a good foundation of lots of areas. So oncology and pediatrics and nutrition. And a lot of programs also recognize that as a student, you don't always get your first pick, and that they're absolutely not going to hold that against you. Sometimes rotation sites, you kind of get what you're assigned, and that's understandable.
Thank you. We have another question from Hui Lee. I signed up for acute care infectious disease elective. Could you let me know how to prepare for that rotation best?
Oh, I'm so excited you're doing infectious disease elective. How to prepare for it best? It's kind of going to depend on where you're doing it. I had a pretty tough site when I was a P4 at Touro. I did my elective ID rotation at Kaiser Walnut Creek, and we had a topic discussion every day. And it was either a drug class or a disease state. And doing one every day is asking a lot after you've already, you know, put in 8 or 12 hours on site. I don't do that to my students now. We do maybe 1 or 2 topic discussions a week, but it'll depend. One of the places I rotated at, it was really actually kind of fun. We walked through the pharmacy and they would point at different antibiotics and they would ask me, what does this treat, or what would you use it for? So just refreshing yourself on your bugs and your drugs in terms of your spectrum of activity. If you've been able to kind of synthesize your disease states during pharmacy school, you can kind of refresh yourself. Or if you haven't, and you already have your NAPLEX CPJ study material, I kind of wish I would have done that as a student on rotation, had that material already, because you can quickly go to that material and read through what are the most important things about that disease state. So in hindsight, I wish I would have had the review material as a P3 rather than a P4. So let's say you have a patient with pneumonia, you can just pop up in your notes or pop open that review book and kind of check how pneumonia is doing. But yeah, go over your bug drugs. You'll talk about different patients when you're there. But yeah, I hope you have a great experience. I'd love to hear about it. So send me an email.
Awesome. Any other questions? I'm not seeing any others in the chat. I'm trying to keep an eye on it. Don't be shy. It is really a treat to have an expert with us, and someone who has, walked in your shoes, getting there during and after.
So I have a question, Dr. Donnelley, that was sent to me directly, and from the perspective of a new student coming into the program, how important is it to know the top 100 drugs, and what recommendation or approach would you suggest coming into the PharmD program?
Oh yeah, great question. I don't know that you have to know them coming into the program, but once you're in the program, we're probably going to want you to know the top 200. And I'm a everybody kind of has their own way of learning. I'm a flashcard person. And so you can order flashcards that are pre-printed already, and you can quiz yourself, or you can handwrite your own. I know that technology has moved beyond that now, and you can make flashcards online and quiz yourself. So you kind of find a way of testing yourself. Maybe you work with a buddy or a small group, however it takes to learn. The beauty of learning those top 100s and kind of knowing the brand and generics, some of the counseling points, is that you're going to see them over and over again. And when you get into the therapeutics, you're gonna recognize the names, because a lot of the first year feels like a foreign language. Some of you coming in will have some pharmacy experience or some medical experience, and some of you won't. I had a couple engineers in my class. I had a music major in my class, so we had a pretty diverse class. I just kind of find a way to learn them and study them, because they'll show up, but they'll show up again and again. And then when you're in practice, you're going to see them and you're like, I know this, I got this.
Thank you. Tony, do you have other questions on your end?
No, that was the one question was sent to me privately. But again, I would like for everyone to ask this, take this moment, this space, safe space, to ask questions, especially those that are getting ready for residency or third and fourth year. What an opportunity to have this awesome individual here to answer your question. And I know that earlier she was on, Dr. Lucinda Chan, those experiences and others. This is your moment. I see some very familiar faces. I don't want to call out any one person, but this is that moment, again, in a safe space to ask your questions in the chat or unmute and ask the question.
Hello, Dr. Donnelley. This is Sammy. How are you doing?
Hi, good. How are you?
I'm good. Thank you for your time. And I just talked before Tony picks on me. So infectious disease has been great. I see it in every acute and sometimes like in the outpatient, either an ER or an ICU or even oncology, no matter where you go. But we deal with physician recommendation. We give recommendation every day. If you can, if you can recall and like the example where you actually recommended a medication and the doctor said, no, and you don't see he have evidence behind what he's saying. Maybe actually the bug is resistant and he's depending on an outdated data. So how you handle that, if you can just explore that. Thank you.
Man, hot seat. This is a question we would ask somebody we're interviewing. And it's a great question. And I can think of a lot of examples, but the one that definitely sticks in my mind the most was one that I was very concerned for the patient. So we had a patient, she was younger, probably 18 or 20 years old, she had Down syndrome. So, you know, kind of definitely a challenge to deal with. And, you know, she was having a hard, kind of scared just being in the hospital environment. And what happened is she had an infection of a finger, and it was osteomyelitis. And so it actually went down to the bone. The attending at the time, the ID attending, so this is the ID specialist, we've been called in to help consult on a ortho patient. The orthopedic surgeons are handling this case. And the infectious diseases attending, so the specialist, recommended a course of therapy that, based on the literature, I recognized as being too short. It wasn't going to be long enough. The patient's blood cultures were positive, and it's hard, and it takes a lot of courage. But also, you have case forward, and so I had to put the case forward that the blood cultures are positive. We have to check them again. I feel like the amount of antibiotics we're giving, it's too short. And the physician says, no, they surgically remove the infection, it's fine. And I said, but the blood cultures are positive. That means that the bacteria has moved through the blood. And it took going back to the physician with the paper, with the guidelines, and saying, you know, I don't think this is right. And that's hard. It's definitely hard. But hopefully you feel, you know, confident in your skills and your recommendation to make that. And a lot of times, and I've heard this from other people, the physician maybe wants to take a moment to kind of digest or look at the information, or maybe they're just, you know, they feel bad that they've made a mistake, or they've been caught off guard. And so they like, oh, let me think about it, or I'll look this over. Or I've actually had people tell me, I'm the doctor. And you say, and my response is, and I'm a pharmacist, and I'm a drug expert. We've had cases where therapy plans are missing in a component. It's not a complete regimen. You're missing something here. And it's hard to tell people that. But, you know, people kind of get used to it. Sometimes people in the hospital call us the antibiotic police. We don't want to be called the antibiotic police. I feel more like I'm an antibiotic protector. But, you know, throughout the day, we're checking orders for accuracy, and we're helping patients. I've had physicians answer, I call them before, and they answer the phone, and they say, and you know what they say? They say, what did I do wrong? Oh. Because you're calling them, and I mean, they're hearing from a pharmacist, and unfortunately, most of the time we're not calling to say, hey, you did a good job. We're calling because we're pointing out something that needs to be fixed. Or like you mentioned, there's a bug drug mismatch. And early in your career and in your training, one skill that we kind of teach is, you know, I'm new at this, I'm still learning. I don't understand why we're using this drug for this resistant bacteria. Can you explain that to me, or can you teach me? And hopefully they'll be open to it, or maybe they'll kind of realize what's happening at that point. But yeah, it's hard. It's by no means easy to point out that to somebody. And that's why as pharmacists, we just have to be, you know, good communicators, but we have to be, you know, we know our stuff, and we're responsible for that patient as well. I had a specific example, and, you know, not infectious disease related. It was related to a fentanyl patch. And, you know, you guys, those of you who have already gone through pain education, you know that a patient has to be opioid tolerant in order to receive a fentanyl patch, or it can actually be deadly. And I had to page a physician to tell them that their patient did not qualify for a fentanyl patch. And I tried to explain to the physician that their patient was opioid naive and not tolerant. And the physician said, I don't know what that means. And at this point, I was, you know, kind of a bit ruffled. And I said, well, it means your patient's not getting a fentanyl patch. And a lot of times, physicians that are still training or learning, their automatic response or kind of a defensive mechanism is to just say, that's what my attending wants. And you say, fine, let me talk to your attending. And it's gonna, it takes courage, but you know your stuff. And if you're right, you're there to advocate for the patient and keep them safe. Sometimes we have recommendations that aren't accepted, and we know that there's multiple ways to treat something. If it's something that, it's similar, you could treat it with something else and that's probably okay, and you're trying to make a recommendation because maybe it's more cost effective, or it's something that you have in stock versus something that's non-formulary. Sometimes those are a little bit harder to sell. And, we do keep track in our stewardship program of how many recommendations are accepted, not accepted, or rejected. But yeah, you keep advocating for the patient. If you're right, show them the evidence, make your case, let them think about it. But again, no patient harm, right? We're not going to let that happen. I'm not approving that fentanyl patch. There is no way I'm putting my license on the line to give you something that I know could cause harm. That is definitely where you draw the line. And sometimes you need help. Let's say that you present the information, the physician still doesn't agree with you. You go to your preceptor, you go to the supervisor, the manager. And we definitely have a kind of a chain that we go up. When a physician wants something and we don't agree, sometimes we have to take it to the chief medical officer. Yeah. Great question. Woo.
Yeah.
Yeah, theirs are getting harder.
Yeah, thank you so much, because I have it like every day. Like I had it in the ICU where they just want to start throwing the big guns, and I had it in the ER. They want to give a big guns and let the patient go home. Then we're having another complexity of like the C. diff when they just threw all those big guns on the ICU, and we actually saw some resistance that shouldn't actually grow, but it grows because of the choices. So
Yeah.
thank you so much.
Yeah.
I think we're going to wrap things up, but we have time for maybe 2 more questions. I see you, Nayli, and there's a private question here, Dr. Donnelley, to you. What was the most challenging course you had in pharmacy school, and how would you suggest we prepare for it going into pharmacy school? And then the last question to Nayli will follow, Dr. Donnelley.
Yeah, that's oof. So I don't know, me personally, if I'm good at something and I like doing it, you want to do more of it, right? Because you're like, oh, I got this. This is good. I like this. I'm willing to put in the work, or I'm super interested. And if it's something I'm bad at, like video games, then I just want to avoid them altogether and not do them. So I really like track 4. So I'm willing to put in the work to learn the material because I enjoy it. Track 2 for me was probably the hardest, even though I loved the mechanisms of action. Kind of just the maybe some more of the chemistry or how the drug is metabolized. Like some of that was harder for me to digest. Like I wanted to know about the patients. I wanted to know how to treat the patients and what to monitor. But getting into the more obscure part of some of the PK/PD, that was whew. So for me, and I hear different things from different people. Some people have a really hard time with track 3 with some of the laws and the insurance and the study design. So people have their strengths and their weaknesses, and you just kind of have to work harder at some of the stuff you don't love. Yeah.
And that's really true, right? For any profession, there's going to be like the things that you love, and then the things that you're like, I know I need to know this, but I am not 100% in love with it. Yeah. Nayli.
Good evening, everyone. Hi, Dr. Donnelley. I had a question for you. So as a specialist at a large academic center, I suppose that you do a lot of research along with your clinical work. So my question is, what proportion of your time does your research take, and how does it incorporate into your workday?
Yeah. Thank you. It's good to see. It's nice to see your face.
Oh.
I'm sad it's not in person in real life, but it's great to see you. So research can kind of depend on your role and where you're working and how that's divided up. We're in a hospital, and so I do have some protected time for my learners so that I'm teaching the residents and I'm teaching the students. And part of that teaching involves their research. So I would say like every other week, I have a dedicated protected day for their learning. And that's not just research, that's also their evaluations and developing the program. Outside, while you're working and while you're practicing, you notice things and you have, questions come up as you're working with your teams. So it's not like you have to say, okay, I'm going to stop working on patients and work on research. You could be working on patients and you'll say, oh, I noticed that a lot of these patients have this problem. Why don't we look more into this? And that's how you develop a research question. Or it could be while you're working with a team might say, I want to look at how what these drug levels mean, what's toxicity and what's normal. And so it's ends up becoming part of the workday, and also becomes maybe some extra work. So it's not like we have there's some places where you like part of your job is research, so you're doing bench research, and we do have a pharmacist that does part-time pharmacy and is employed by the School of Medicine to do bench research. So it depends on the role.
Yeah, I see. Well, thank you very much. I was very curious how researchers come up with those questions, because some of them are so specific that it just blows my mind.
And the specific questions are great questions to ask. Yeah. I think that in research or in clinical studies, if you ask too many questions, it's hard to find significance or just not get overwhelmed in the data. So asking like very clear, very specific questions. I just today had a meeting with a first-year resident who is looking at C. diff patients that have a history of C. diff. And when they come into the hospital, can we prevent recurrence by targeting those patients? Because we know that they're at the most risk of having recurrence. So a really, really specific question, because you want to be able to do it in a dedicated amount of time. Yeah.
Thank you very much.
You're welcome.
Well, we are coming up on the hour, and I want to be so respectful of everyone's time this evening. We are about 2 minutes away from 7 o'clock. I want to thank everyone for being here with us tonight, but especially Dr. Monica Donnelley. Thank you so much for sharing insight and experience and all of your guidance in terms of becoming a pharmacist and being a pharmacist and the choices that you've made. Thank you so much for being here tonight. Is there anything that you'd like to share as we close?
Well, no, it's an honor, and thank you, Jody, and thank you, Tony, for this opportunity. For me, one of the greatest things is still being able to be connected with the school and work with the students, and your passion for patient care and the profession is inspiring to me, and definitely one of the highlights of my career.
Great. Thank you so much. Everyone be on the lookout. As I mentioned, we'll be hosting career in pharmacy webinars. We'll have one more this month and another one in March. I will be sending out invitations. Tony will be sending out invitations. We're going to make sure that you guys get those invites. Different hosts every session, guest speakers. Just a really great time and a really great opportunity. And I could not have come up with a better way to spend my evening. So thank you all, and have a great evening. Tony?
Thank you.
Thank you again, Dr. Donnelley. Thank you everyone for attending, and be well, be safe.
Good night, everybody.
2021 is looking better. Thank you.
Ah, thank goodness.
I know. Let's get out there and vaccinate.
Yeah, right.
Ready?